Currently, we have 4,008 cases in Ingham County, 55 deaths, 10 hospitalized folks, one of those in the ICU. And then we have 1,104 that are currently active cases, but are home outpatient. And then we have 2,839 recovered. So we have a 1.4% case fatality rate, which is calculated on confirmed cases and confirmed deaths. So right now we are looking at hospitalization trends that are on their way up. So you can see where we were back in early April when we first started seeing hospitalizations, and then we dropped down. Really late April, early May, we started dropping down and really held down for quite a while. And those are going up now. So we are hearing from our hospital partners as well that they are seeing increased numbers of cases. These would be Ingham County residents only in our local hospitals. So there are other individuals, Eaton County, Clinton County, Livingston County, Shiawassee County, any number of people that end up in the hospitals here because of their regional nature. I split this graph into two different graphs because the hospitalization numbers were getting lost in it when you have everything. So when hospitalizations are a total of everybody recovered as well as active, then you it's always going to be a tiny, tiny number. So what I've done here is, instead of showing you hospitalized and all of that in this case, this is basically our active cases. So 27.5% of our cases currently are active, 70.8% are recovered, and 1.4% deceased. Then this isn't that impressive looking either, but what it does is it keeps us a little bit more relative with what our numbers in terms of hospitalizations are. If I included it on that other graph, it was 0.1% in the hospital and 0% in the ICU. So went to our active cases. So about 99% of our active cases are home, and the others are hospitalized. The other 1% about are hospitalized or in the ICU. So 0.8%, not quite a percent hospitalized, and 0.1% in the ICU. So our cumulative curve by date of onset now looks like this. So we have really not been able to get a good leveling on this since, I would say, back in early to mid-June. This was getting nice and flat for us. We actually had some days where we had no cases, and then this started going up, and we were about to flatten out, and then we hit this, which also is still not flattening out. So our incidence curve looks like this right now. So these are our cases in March, April, and May. This is what happened when we had a few outbreaks in mid-June to early July. And then this is what we're looking at as the month of September has kind of come by. So we're still looking at cases certainly not leveling off here. Statewide, nationwide, we're seeing a resurgence of cases. Percent positivity also has climbed. We would really like to see ourselves below 3%. 3% is the state's threshold for low risk. And then you get into, I believe, 3 to 7% is medium. So, we climbed up to close to 10% on a day here, and we're really hovering here in a little over 5%. We're over 5% right now. So if you look at that in a rolling average, so here are our cases in the gray bars, a little smoothed out here because of the rolling average. But you can see what's happening here with percent positivity, which went up and started coming down and is on its way back up again. So we have a percent positivity that's certainly higher than that 3% threshold that we would like to see. So when we look at cases by zip code, we are at 1,620 to 1,630 and 48823, 511 to 520 and 48911, and then we go on down from there to a couple of other Lansing zip codes, and then the 48864, which would be Meridian, Okemos. So just going with the rate map now, that shows clearly, even by population, East Lansing is got our highest number of cases, followed by 48911, and then you see that 48910 and the Okemos zip code, as well as out here in Williamston and Leslie, are kind of our next highest shaded, and then Hazlitt, Mason, Holt, and this zip code out here is out by the airport. So a heat map countywide looks like that right now. We can zoom in, and you can see, you know, we used to be paying attention to these were yet nice bright yellow spots in 48911. But now because of the heat, you know, related to East Lansing cases, which clearly are way beyond the number of cases in any other zip code. So we can zoom in on that and see basically spots in East Lansing a little bit more separated out as opposed to that just one big blob. So some of these very, you know, concentric circles, you know, like this are some apartment complexes where people will all have essentially the same address. So this is an apartment complex just outside of East Lansing in Lansing, and this is an apartment complex over near Hagedorn Road over in East Lansing as well. So right now we are 50% 50% female, 50% male in our cases. Currently we are basically still looking at 19% of our cases 10 to 19, 41% of our cases 20 to 29. This is cumulative since March 12th. If you looked at those numbers like in the last 2 months, you would see a preponderance of cases in this 10 to 19 and 20 to 29 age group in terms of this most recent spike in cases. So I did this last week and can show you again that when we look at that 10 to 19 age group and pull out the 10 to 17s and look at the 18 to 19-year-olds, that 19% separates out like this. 16% of those are 18 to 19, the other 3% are 10 to 17. If you look at that 20 to 29 age group, which was 41%, 35% of those are 20 to 24, and 6% are 25 to 29. So if we look at our 18 to 24-year-old age group now dissected from those 10-year age group gaps, 52% of our cases since the beginning of this pandemic are now in our 18 to 24-year-olds. When we look by race, 67% Caucasian, 14% Black or African American, 6% Asian, 11% other, and 2% unknown. So we're tightening that prevalence rate gap, but we still do see a slight difference in numbers of cases by rate when we look at our Caucasian population versus our African American population. If we look at cases by ethnicity, we're still, I think we've been hovering right around in this range for quite a while now, 83.1% not Hispanic or Latino, and 8.1% Hispanic or Latino, and 8.8% unknown. So again, looking at that by rate, we do have that slight disparity between our non-Hispanics and Latinos and our Hispanic and Latinos, which are a rate of 1,400 compared to 1,235. Deaths by age, we do have more deaths, so we continue updating this for you. 47.3% over the age of 80, 32.7%, 70 to 79, 10.9% are 60 to 69, 7.3% 50 to 59, and 1.8% 40 to 49. By sex, they are 50.9% male and 49.1% female. And by race, they are 65.5% Caucasian, 27.3% African American, and then 3.6% other, 1.8% Asian, 1.8% unknown. So if you go back and look at cases by percent and by rate, you will notice that we were about 15% African American compared to, let me go back so I've got this number correct, 14%, which is not that much, as you see by looking at the rates, that much of a disparity in terms of cases. It's slight. But when you look at deaths, then we see this very distinct disparity where 27.3% of our deaths are African American, which is definitely significantly overrepresented in terms of percent of deaths versus percent of our population. When we look at the non-Hispanic versus Hispanic or Latino by percent in deaths, we are 90.9% not Hispanic or Latino, 5.5% Hispanic or Latino, and 3.6% unknown. This is, again, our MSU related cases dated by onset. So we saw this very significant spike in cases early to mid-September, and then those have been tapering off. You'll see very low numbers like today. Again, these are put in by onset, so it'll be a few days before we have reports, lab reports back that give an onset of, say, today. So those numbers get populated as we move forward and get dates of onset. A referral date is put in there where onset is not available. That referral date means the testing date, say, of somebody who was asymptomatic. Since there's no way to determine onset date, we use that referral date or test date for that case. Looking at percent positivity, we see basically this percent positivity in the county, which came up as this percent positivity in MSU cases was very high and has stayed fairly high, come down a little bit. But you see we were trending down here with percent positivity in MSU cases and are heading back up and then maybe leveling off here in the, I don't know, 10, 11, 12% range again. This is both of those curves on a rolling average. Again, we're seeing this go up, but cases go down, this gap in between here. Anytime if you go out to, say, the COVID Act Now map or the Harvard map, which is at globalpandemics.org and a few others like that, when you see a number of testing, percent positivity in testing, say 10%, what they will tell you is there is insufficient testing going on. We have plenty of testing capacity. So when we see a positivity rate that high, then we need to be doing more testing in that population group. So those cases by week look like this. So you will see this on MSU's dashboard as well. And again, the cases for this week will be published next week. And those do get updated. So you'll see these numbers change slightly as we get updates with onset dates moving forward. And then this is just a cumulative graph showing you basically that onset of MSU related cases and the steep curve there, which caused the steep curve here. This is leveling out, and we're now working with basically, you know, the secondary, tertiary, the cases that are basically coming as a result of multiple, you know, rounds of transmission to other people now in the community in terms of increased transmission rates. So there we are. So that's where we are this week.
Thank you, Linda. I have a question from Mark Bayshore. He says, at this point, what kind of fall and winter are you anticipating in Ingham County regarding coronavirus case counts? And then he goes on to say, how confident are you that various agencies, ICHD, DHHS, etc., will be able to guide the county through the fall and the winter without significant COVID upheaval?
Well, that's one of those crystal ball questions. So I certainly expect for us to be dealing with COVID through the winter, probably into early 2021. What happens with regard to cases is largely going to depend on people. It really is largely going to depend on the degree to which we can get strict adherence, or at least really, really good adherence to mask wearing, social distancing, indoor and outdoor gathering kinds of restrictions. And then, of course, you know, hand hygiene becoming the next. So it really is going to depend on that. We certainly, you know, expected to see an increase of cases in the fall. You know, perhaps a second wave. It's really hard to tell when the second wave comes, when it was really hard for us to ever control the first wave. So, you know, it's the data just kind of muddies all of that up. How confident am I? I think we see that with the recent Supreme Court ruling, the putting in place of MDHHS orders, as well as a few orders here in Ingham County, that many things that are critical to stopping that transmission are back in place. But we have a public perception that all of that was overruled by the Supreme Court. It's all unconstitutional. We can't do it. While that is true of what happened with the governor's orders, that is not true of the MDHHS orders and other public health orders, which are written under a completely different statute. So I think we've got a little bit of work on our hands. I think we were doing quite well before with a lot of that adherence. Obviously, we didn't have very good adherence in our 18 to 24-year-old population. And we saw that borne out in, bars and restaurants and parties and gatherings and those sorts of things for sure. But we did have pretty good adherence, really, other than that. So it's a matter of getting that back into people's heads that while the governor's orders were overturned and the statute that she based them upon was unconstitutional, not her orders. The 1945 law was what was found unconstitutional, and that was the basis for her orders. So I think it's going to take us a little bit of time to get people back to where they realize that these orders really truly are in place. They really truly are orders that are in effect, and they are, required. They aren't the orders that were overturned by the Supreme Court. And we do also have right now a little bit of struggling with regards to enforcement, because even at the state level, state agencies are kind of a little bit on pause with what the state is directing them to do with regards to enforcement. So, we're back in the enforcement thing. Enforcement was always, quite honestly, has always been a challenge. So right now, as people come into this kind of like period where they think all of these rules and orders went away, it is just basically getting that back down, getting that adherence again, getting some enforcement. And if we can do all those things, we should fare pretty well. Those are big ifs.
Thank you. Next, we'll go to Robin Erb.
Hello. Yeah, I don't know if this would be a technical question or what you'd classify it as, but the word resurgence, I don't know if what we're talking about now with this, continued increase again in cases is really what we call that second wave, or is it just a continuation of what was already happening? Can you kind of help me with the definition?
And that's what I was trying to say. That's really hard to figure out. If we had, think back to early to mid-June, where we truly had gotten things under control. If that had remained and we hadn't had all of this just like, lack of control of our first wave, then it would have been fairly easy to see that first wave and then everything down, 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 and then the second wave. What happened in late August, early September is really a little perhaps early for a true second wave. You would expect that real, heavy second wave to start coming, a little bit later in the fall, kind of along with flu season. So as we move into October, that's kind of to be expected. I'm not sure that it was expected in September, but again, we're basing that on what we would see for flu cases and when we would expect that wave of respiratory illnesses. And when we see them peak in February, March for flu. We see them start in October. So, but that's a disease that people have some residual immunity to, and we have a vaccine for. So when does that wave come on when we don't have all of those things? It's really kind of hard to tell. And again, the kind of lack of control that we had of the first wave just kind of muddies that all up and makes it hard. It just makes it hard.
The trough wasn't deep enough to. Yeah. Okay, that's fair.
Well, it dropped, but it didn't stay dropped, And then if you look at the real big surge in cases, and you realize that the vast majority of those were 18 to 24-year-olds, then how do you call that a true second wave? A true second wave should be a little bit more distributed across our population, I would think. So.
Okay. Can I do a follow-up then?
Now, as we start to see things come up, now we might be heading into our true second wave, or just like it's all muddied together into one just big thing at this point in time. It's really hard to tell. So,
Well, and that's kind of, I guess part of this too is trying to understand, like we've been talking about this 18 to 24-year-olds. So theoretically, then the adults that are around those 18 to 24-year-olds, we would expect them to be infected at some point. Is that
Right.
actually happening now, or is that kind of
Oh,
guesswork?
yeah, that is happening now. That is part of the increase in hospitalizations in those age groups, deaths in our older age groups. We're seeing those things start to increase. So, what you would expect to see is that very giant curve kind of drop off. And then as you can see right now, it's kind of starting to level off a lot higher than we'd like it to be and trend back up, as well as our percent positivity being higher than we'd like to see it. So it's going to be challenging to get those things suppressed as we're also heading into what might be a second wave. Again, if we can get adherence to, I just keep saying to people, 5 basic things like wear masks, socially distance, don't have large indoor gatherings, don't have large outdoor gatherings, and wash your hands. And quite honestly, if we could all just like make a pact with each other to do those 5 things, we wouldn't even need a whole lot of orders requiring people to do things or not do things or whatever. It's like, everybody, let's just take a pact that we will all do those 5 things. That would be remarkable and would be remarkably effective as well.
Next, we have Scott Pohl.
Hi, Linda. As I watched you go through your slides today, I want to make sure I've got a couple of things right and then ask you to respond. One is that it would appear that about half of the cases in the county have been between the ages of 18 and 24, and yet no deaths in that age range. In fact, it looked from a different slide that you haven't had any deaths in the county younger than 40 years of age. Besides the obvious, that older people are more susceptible and have greater symptoms, and that in many more cases lead to death. Is that telling you anything besides the obvious along that line?
No, I mean, and we've seen that since the beginning. I mean, you go all the way back to when we were watching this in China, before it even got here, and we were looking at statistics, and statistically the number of people 70 or over or 80 and over that got sick and died compared to the younger age groups. For a while there wasn't even anybody that had it in younger age groups. Now we know better than that. They probably were, a lot of them, just asymptomatic or very mildly symptomatic instead of severely ill. Keep in mind, early on, a lot of the testing, because there was limited testing capacity, was only testing the severely ill, which tended to be our older population. So, yes, it is true that 18 to 24-year-old age group is far less likely to be hospitalized, far less likely to have serious illness, far less likely to die. All of those things, however, do happen. They do become seriously ill, they do get hospitalized, and they can die. So that's, we need to remember that. And then we also just, I've been saying it ever since these cases spiked up in September, is that what concerns me is that is a really high level of transmission in this community. And that while the people who were currently sick, largely 18 to 24 with the illness, were not likely to die, were not likely to get seriously ill and hospitalized, although we did have a couple of ER visits even in that age group, that they would then pass it to someone who then would pass it to someone, and down the road, there are going to be anonymous people, because of this very high level of transmission in the community, that are going to be in the hospital and are going to die. And I said at the time, and I'll say it again, I was very concerned and remain very concerned about hospitalizations and deaths in this county in October, as we're starting to see in November, as a result of the just astronomical surge in cases we saw in September.
If I can have a real quick follow-up, the numbers that associated with MSU in recent days, according to a different graph, appear to be at or near 0. What would you attribute that to? Do you have some optimism that MSU can keep that number low or close to 0?
Those are good questions too. Keep in mind, when we look at the MSU numbers, we also see a very high percent positivity. So every time somebody gets tested, the likelihood that they're positive is high. Now, that's one of two things. We're only testing the severely ill, or we just plain out are not testing enough. When you have a 10% positivity, there are other cases out there, right? That's just what the statistics will point you to. So, and that gap between percent positivity and cases, we said all along, it's like when you see percent positivity stay about the same and you see case counts go up, what that means is we're testing more because we're getting more cases, but our relative percent positivity is staying the same or is low. I would argue that the opposite is also true. If we see that percent positivity going up, but we see cases going down, that is probably an indication of not doing enough testing.
Thank you.
Dave Ackerley, go ahead.
Hi, Linda. I want to follow up more on the MSU numbers. I'm a little bit confused here. Maybe you can clear it up. Your weekly number for them, I think on your graphic that I should have grabbed, was 52. Is that right? I think.
For this week, yes, 52.
All right, and
52 for basically the week of October 5.
Right. Okay. So their dashboard says 49. They're pretty close, and yet the state numbers that come out, the Monday state number for the week, for the October 5 week, they go Monday to Monday. I keep kind of a rolling total. It went from 1420 to 1531. So that's 111. Any idea why there's such a disparity on the statewide total of cases added to the MSU roll in, case site specific MSU?
So are you guys seeing my MSU graph again now?
I am.
I can't find my screen share button. Oh, there it is. Stop sharing.
Okay.
Share. Here we go. So let's look at this graph again since you asked about it. So two different things are going on here. So the MSU, when they put up their dashboard, started the week of July 27th. That was their choice, and because our numbers are more complete than theirs, we have been giving them these numbers weekly. They update their dashboard on Monday. So the numbers for the MSU related cases are starting July 27th through current. My staff updated this graph today. So remember, based on onset. So Monday, we published a graph or gave MSU a graph. So there are some more cases that we now have reported that belong in the week of October 5th based on onset date. So that's why that number is different. Now, in terms of why the number on the MSU dashboard or this slide and why the number at the state are different is that we are calculating numbers from the state beginning August 24th. That is the threshold that the state used for calculating numbers. And there are a couple of other variables that are different in terms of what the state is counting versus what MSU was counting, and we agreed were relevant things to count or exclude. So for example, if there's an MSU student who tests positive and is fully online in a completely different town, we don't count that in our MSU related cases because we're counting MSU related cases here. Now that might get counted on a state dashboard because of the way, although it shouldn't get counted on the state dashboard either. The other thing is that there are some what we call probable cases that are in this MSU related dashboard and the state doesn't, or is it the other way around? So there's some probables in there that also are a slight difference between the two graphs. So that's kind of an explanation. It's dates that are different. And then I updated this today. MSU only updates theirs once a week. So they have, the graph that they have was as of Monday, as opposed to as of today, which I know seems like very little time, but things change that fast. So
could you see though, from the state angle, and reporters around the state who aren't local will look at that and say, now 1,531 cases tied to the outbreak. And if they're counting those who are distance learning somewhere else, it puts up, that number starts to get a little fuzzy.
No, actually, that number is also people that are in this county. So the MSU outbreak, we changed the outbreak identifier if it's somebody that's completely online. So that does not get counted in that MSU Ingham County count either. So if they're a non-Ingham resident or a non-state resident, then they don't get reported to the state in that number either.
Okay. Okay, thanks.
Mhm.
I don't currently have any questions in the queue. If you have a question, please feel free to go ahead.
I'll add another one if you don't mind.
Go ahead.
So when we're talking about, okay, so the MSU cases are falling, but we were seeing, you know, an increase in hospitalizations and other cases. Do we know that those are related to the MSU cases? Does that bear out in contact tracing, or could they be something else?
No, I mean, no, it doesn't. It basically it bears out as a delayed indicator. So the way you would directly tie it to it is to say that a secondary case from an MSU student is now hospitalized. But typically what it is it's not that one, or you know, it's once it's passed several times, we can't directly tie it back. What we do know is that when we see increased transmission in the community cases, the delayed indicator of that is increased hospitalizations and increased deaths. And time again, that has borne to be true. So we saw it. We saw basically an increase in cases mid-June to early July. There were a few different outbreaks going on at that time, but we did see that surge in cases, which looks really tiny now compared to what's going on. And then by the time we got to August, if you look at that hospitalization graph, they did go up a little bit, and we had 10 deaths in August as well. You can't directly tie that to any of that. Well, you could if one happened to be a secondary case of that. We don't have any direct ties like that. I don't know of any direct MSU secondary case that's hospitalized or has died. What I do know is that we saw just astronomical increase in transmission in this community, and it will ultimately impact this community. In fact, it is.
Thank you.
Can I ask one more real quick question?
Go ahead.
A couple of weeks ago, I missed last week's call, so forgive me if this has been brought up, but a couple of weeks ago, you brought up there had been an increasing number of complaints about bars and restaurants who weren't adhering to separation of tables and mask wearing and so on. Has that trend improved to your knowledge?
It has indeed. Yeah. We had some, we went down and had some meetings with some bar and restaurant owners. Our environmental health staff did. Matter of fact, I'm about to hop off of this and get on with the Responsible Hospitality Council with East Lansing. So they, as a council, have been working with their members as well. So we are seeing better adherence to what was going, you know, bar and restaurants and capacity and, you know, all of the different things that actually make a bar or restaurant a safer place to be.
Thanks again.
Next, we have Rachel Sweet.
Hello. Just a recap. I don't know if I misheard you or misunderstood. Did you say that there possibly could be a second wave if people continue to not adhere to the social distancing rules? I missed that for the fall.
So we fully expect a second wave. So it is basically a matter of how bad is that second wave going to get. So the degree to which we can adhere to mask wearing, social distancing, you know, limiting indoor gatherings, limiting outdoor gatherings, washing hands, that sort of thing, will help keep that second wave minimized. So that's, you know, we've known, you know, since this came along that in absent a vaccine or a cure, we should fully expect a second wave. But we also know that, you know, Dr. Fauci said, many people have said, if we can get strict adherence to these things, then we can make it through that with a lot less significant of an impact. And it is going to take that.
A second wave in the winter time, or we just don't?
It's hard to tell. I mean, generally, you're talking fall. If you go back and look at, the 1918 pandemic and when that second wave started popping up, it basically, it's going to align with, when do respiratory illnesses start to become more prominent again. And it does tend to be, in that fall and winter time when we tend to go indoors and we're in more, congregate settings and, sharing airspace with people and not being outside as much. And that's when flu season hits us. That's when a lot of our other types of illnesses and respiratory illnesses hit as well. So, you're talking about a virus that we haven't really been able to predict all the time since the beginning of this. So we're basing, the second wave on the fact that that's what we've seen with influenzas, especially influenza pandemics. And as far as when that second wave might be, we base that on what we typically see with respiratory illnesses and when that season tends to spike up.
Okay. Thank you.
That's as good as I can do right now.
Thank you.
Do we have any more questions for Health Officer Vail? Last call for questions.
I'll do one more. There are some schools that do plan to go back to school or do hybrid classes in the fall, saying that there could be a second wave. Are you concerned about that at all?
There's a really good matrix out there that determines metrics for how schools can go safely back to face-to-face learning. And I do encourage the school districts to, look at that and guide their decision-making with that. And we certainly can have cases in the community. We can have a certain percent positivity in the community, and we can still have face-to-face learning. But there are other things. As those case numbers go up or percent positivity goes up, then the schools have to take extra mitigation precautions. And it really is going to be dependent on the extent to which they can make that actually happen, whether or not it is good for them to go back to face-to-face learning. So, it's really hard to tell. And also, they can always pull back as well. So it's those that I will tell you that the whole school thing is probably one of the hardest decisions that people are having to make. We come in as public health officials and say, here are the metrics, here's what can be, but you've got school districts trying to weigh the risk of COVID and potentially the impact of that, and also looking at what's happening with education being in a completely virtual format, which has its downsides as well. So they've got to weigh the differences between those two things. I mean, I don't envy that decision, and like I said, I don't make it. I just give them advice in terms of what the numbers look like and what that means in terms of what they can do, and whether or not they're able to take these mitigation steps in order to minimize it. My daughter is a middle school teacher, and she's really struggling with what's happening with her students as well. So not being able to see them, not being able to engage with them on an individual basis. You're talking 6th and 7th graders, sometimes becomes challenging because it's that interaction and that relationship that she has with each and every one of those students that helps her figure out how to engage them to make sure that they stay on a path of learning. And so that is going on too. She's deeply concerned about that. So educators have got that to consider at the same time that they've got to look at what's going on with COVID. And it's a challenging space to be in.